To this Experts Online on CI fitting for single-sided deafness and the road to binaural hearing with optimizing fitting in cochlear implant recipients with single-sided deafness. My name is Reinhold Schatzer. I'm team leader here at MED-EL for sound coding, and it's my pleasure to serve as your moderator here today for this Expert Online. Before we start, a few quick participant tips. Please name yourself if you haven't done so in the registration. And to avoid background noise, please mute your microphone if you do not speak, and also mute your phone. For a stable internet connection, please close all other programs. And at any time during this Experts Online, your comments and questions are more than welcome. So please either raise your hand or type in the question in the chat. There is also English captioning available. So if you go to your Zoom menu bar and click on closed caption, you will also see the captioning in English. It's my great pleasure today to welcome two exceptional speakers for this Experts Online. Both Griet Mertens from the Antwerp University Hospital in Belgium, as well as Dayse Távora-Vieira from the Fiona Stanley Fremantle Hospital Group in Western Australia, have as much as 15 years of experience in managing implant recipients with single-sided deafness. And they will both share their year-long expertise on this aspect in today's Experts Online. And after their two lectures, we will also have a concluding open Q&A discussion session at the end of this event, where your participation and questions are, of course, more than welcome. Now, to start, let's open up with a question that I would like to pose you as an audience. Either please scan this QR code with your mobile phone, or if you have internet access, use a browser and go to www.menti.com and enter the code that you see here. And then the first question will already pop up for you. So when you have logged in, you should see the first question. And the first question is, the goal of CI fitting with SSD is a close match to the normal ear. Which statement is incorrect? Is it a shallow insertion leads to a greater frequency place mismatch? A large mismatch requires more time for adaptation? Or is it the only advantage of long electrodes is the wide contact spacing? And we already see the results popping in, with the majority thinking the right answer was answer number 3. And we will now hear from Dr. Griet Mertens the response to this introductory question. Dr. Griet Mertens is a professor and coordinator of the Clinical Cochlear Implant Research Program at the Antwerp University Hospital in Belgium. She completed her PhD on single-sided deafness and partial deafness and authored more than 50 articles in peer-reviewed journals. And Dr. Mertens is a leading expert on cognitive hearing science and implantable hearing devices. So please welcome with me Dr. Griet Mertens and her first contribution to this Experts Online. The stage is yours, Griet.
Thank you, Reinhold, for the introduction and for the invitation to join this Expert Online meeting about single-sided deafness. It's indeed one of my favorite topics because the PhD that I defended indeed in 2015 was about the long-term results of cochlear implantation in single-sided deafness. Now, before I start my presentation, I would like to focus on the definition of unilateral hearing loss. And therefore, on this slide, I'm referring to a hearing paper that has been published in 2016. So we define pure single-sided deafness as having one normal hearing ear with a pure tone average of 30 dB HL or better, and a poorer ear with a pure tone average of 70 dB HL or worse. The group of patients with asymmetric hearing loss, on the other hand, is defined as having one ear with a mild to moderate hearing loss, or in other words, with a pure tone average between 30 and 55 dB HL, and a poorer contralateral ear with a pure tone average of 70 dB HL. And we can refer to both groups together with the umbrella term of unilateral hearing loss. So having said this, we can continue with the presentation in which I'll firstly discuss our fitting philosophy that we are using for our single-sided deaf cases in the Antwerp University Hospital. Of course, then you'll need a test protocol to follow up the fitted single-sided deaf CI recipients, and I'll introduce, or I'll suggest in the second part of my talk, a unified testing framework for single-sided deafness. And then I'll conclude my presentation with our long-term benefits of cochlear implantation in our single-sided deaf study cohort in Antwerp. So let's have a look at our experiences about how we fit our single-sided deaf CI recipients. So in our clinic, our single-sided deaf patients are scheduled for the fitting appointments according to the same timeline as our CI patients with a bilateral loss. So that means that the activation takes place on average 2 weeks after surgery. Then the next fitting appointment is 1 week later, then 1 month after activation, 3 months after activation, 6 months after activation, and thereafter on a yearly basis. At the beginning of the rehabilitation process, so at the activation, there are some general tips and tricks that we share with our single-sided deaf patients. So, for example, first of all, we recommend to plug the contralateral normal hearing ear with an earplug in as many situations as possible. We counsel our patient that they will not be able to understand speech from day one, but that this is necessary to eliminate the dominant hearing ear. Similarly, we instruct our patients with asymmetric hearing loss to switch off the contralateral hearing aid in as many situations as possible, again, to eliminate the dominant better hearing ear. In Belgium, there is no reimbursement for hearing rehabilitation in single-sided deaf patients, so therefore we really must count on the motivation of our patients. So we instruct them how to train their hearing with the CI as much as possible at home themselves, using, for example, listening devices, a direct audio input cable or other devices, and this at least 2 times a week. Although it can be very, very exhausting, we really motivate them to wear the CI all day long, so right from day one. And as you will hear in the presentation, the majority of our patients, they were suffering from an ipsilateral incapacitating tinnitus. And because the early positive effect of their CI on their tinnitus, our patients were really motivated to wear their cochlear implant all day long, right from the beginning. I can imagine that in patients without the tinnitus, so without the really early benefits of cochlear implantation, the start can be a little bit harder. We also repeat that it's normal if they cannot understand speech through the CI at the beginning, just to make sure that they are not demotivated from day one. For the fitting of single-sided FCI recipients, we want to have a balance between their normal hearing ear and the cochlear implant, and therefore we want to mimic most natural hearing as possible with their cochlear implant. The first way to pursue natural hearing is by aiming deep electrode insertion. So let's have a look at the clinical consequences of deep and shallow electrode insertion. So some publications mention that a deeper electrode insertion, which results in a closer match to the place of natural stimulation, results in more natural sound quality in CI recipients. Another known fact is that a deeper electrode insertion will lead to a smaller mismatch with any residual hearing. So for example, in our patients with a single-sided deafness and a normal contralateral hearing, with this deep electrode insertion, the frequency allocation in electrical hearing corresponds better to the frequency allocation in the contralateral normal hearing side compared to shallow electrode insertions. Another reported benefit of deep electrode insertion is that greater spacing between the electrodes is possible and that this can lead to less channel interaction. Now, I hear you thinking, why are there also a lot of short electrodes on the portfolio that are not going beyond 1.5 turns? We know from literature that some CI systems are developed to stimulate the cell bodies of the neurons in the spiral ganglions. And some publications showed that there is no sufficient local neural population to stimulate beyond these 1.5 turns. So to investigate whether indeed the deep electrode insertion has the expected benefit, we selected some publication of our group and others to show in this presentation. Together with our colleague David Landsberger, we performed some multidimensional scaling studies. So randomly, 2 electrodes are stimulated and the patient is asked how different are these sounds. So for example, in the first trial, electrode number 6 and electrode number 10 are stimulated, and then the patient is asked to point on a visual scale how different are these sounds. In total, there were 81 trials presented 5 times, so you can imagine that this is a quite boring experiment for the patient that asks a lot of dedication. The typical representation of the results of such a multidimensional scaling experiment is plotted here. And as you can see on the graph, the perceptual location or the perceptual distance of each electrode is shown on the graph. So the mid-frequency electrode contacts are presented in blue and the apical electrode contacts are presented in red. And as you can see in this example, mainly all electrodes sound different from each other. So the main conclusion of this study was indeed that also the apical region, so the red points, the red electrode contacts, are also able to detect perceptual differences. So deep electrode insertion increases the range of place pitch. However, the perceptual differences between the apical adjacent electrodes are a little bit smaller compared to the mid frequencies or the more basal electrode contacts. Another study that investigated the benefit of deep electrode insertion was the study of the group of Buckman. So they investigated the influence of CI insertion depth on the performance using a prospective randomized trial. So they randomized CI candidates to receive the standard electrode array or a medium, a shorter electrode array. In gray, you see the speech perception results over time for patients implanted with the standard electrode array. And in red, you see the results of the patients implanted with a medium electrode array. And as you can observe, there was a trend that patients implanted with a longer electrode array achieved better speech perception results compared to the patients that were implanted with a shorter electrode array. And these results that indeed longer electrode arrays provided better speech outcomes compared to the shorter ones compelled the local IRB to discontinue subject enrollment for ethical reasons. A second way to pursue natural hearing is to keep the frequency mismatch as small as possible. This is, of course, strongly related to the deep insertion that I just discussed. And to investigate the effect of frequency mismatch, we performed some in-house analysis on the effect of electrode insertion depth and outcomes. So all included patients in this study were implanted with the same electrode array with the Flex 28 electrode. So the observed differences in insertion angle were therefore only due to the intra-individual differences in cochlear duct length sizes. Because using only one size of electrode array, so the flexible 28 millimeters electrode, we were able to eliminate the possible effects of spread of excitation, like in the previous study. We found a correlation between the degree of frequency mismatch and the hearing outcomes at 6 months after implantation. So in other words, the smaller the mismatch, the better the speech perception outcomes 6 months after implantation. And this significant correlation disappeared 12 months after implantation. And because of this correlation, that the correlation disappeared after 12 months, we believe that the brain has the capability to adapt to this mismatch in some patients. However, if we want to have the best results right from the activation, so right from the start of the fitting, a better solution is to try to keep the mismatch as small as possible. And we can try to do that by measuring the cochlear duct length prior to surgery and select an appropriate electrode length. If we then still observe a frequency mismatch postoperatively, we can adjust our frequency allocation in our fitting software. Therefore, we need a postoperative CT scan to determine the exact electrode location. And a recently introduced software called Ottoplan allows for these postoperative calculations. Now, this idea of tonotopic cochlear implant fitting, also called anatomy-based fitting, it's relatively new, and therefore further studies are needed to understand the clinical consequences of these frequency mismatches. A third way to pursue the perfect balance between the normal hearing ear and the CI is by adjusting the Maestro fitting features. So for example, in case of functional residual hearing, the Sonnet EAS, or the combination of electric and acoustic stimulation, is a best option to allow access to this natural low frequency hearing. We in Antwerp, we always start with the maximum sensitivity and with the natural directionality. And of course, we go for a fine structure speech coding strategy to imitate natural sound as much as possible. In the bilateral fitting, we also try to balance both ears by making the fitting settings and the manner of stimulation as identical as possible. And the fitting of a single-sided deaf CI recipient is somewhat similar in that respect. Only now we try to match the fitting as closely as possible to the contralateral normal hearing ear. Then, of course, you need a test protocol to follow up your single-sided deaf CI recipients, and therefore the hearing group introduced a unified testing framework for single-sided deaf CI recipients, and I will summarize the most important outcomes on this slide. So, to investigate the binaural improvement after implantation in single-sided deafness, the protocol should include speech perception in noise testing, so that we can evaluate the binaural effects like the squelch effect, head shadow effect, and the binaural summation effect. Also, in view of the improved binaurality, sound localization testing should be part of the protocol. Since the effect of CI on tinnitus plays a very important role in the motivation of our patients, we think that also the tinnitus loudness should be assessed at all the test intervals. Also, quality of life should be assessed. And then last but not least, in my opinion, the most important outcome, one should register the daily use of the cochlear implant in our single-sided deaf CI recipients. For the final part of my talk, let's have a look at our long-term results in our single-sided deaf CI recipient. So the story started in April 2003, when a patient who had fallen off his horse consulted Professor van de Heining. Of course, I'm not allowed to tell this patient's real name, so I always call this first single-sided deaf CI patient Benjamin. So Benjamin was suffering from single-sided deafness after he fell off his horse, and his major complaint was incapacitating ipsilateral tinnitus. Besides the tinnitus, also his ability to localize where sounds are coming from, as well as the ability to understand speech in noise. Both of those capabilities were also affected by the unilateral hearing loss. To obtain the desired benefits of cochlear implantation in single-sided deafness, especially in this long-term follow-up study, special attention should be given to the inclusion criteria. And also equally or even more important, I think, to the exclusion criteria. So first of all our patients must suffer from a subjective tinnitus due to the ipsilateral profound sensorineural hearing loss. Tinnitus was reported to be their primary complaint. They must have normal to moderate hearing loss in the contralateral side, and they must rate their tinnitus loudness on a visual analog scale 6 or more for more than 6 months. Then patients with a major depression or patients with an objective tinnitus were excluded for the study, as well as patients who were not willing to attend the follow-up or the rehabilitation sessions. So Benjamin and also all the other study subjects, they met the inclusion criteria, and in order to reduce the tinnitus, which was the major complaint, Benjamin was implanted with a cochlear implant in a single-sided deaf ear. And so were all the others as well. Then we divided our 23 patients into 2 categories, so 12 with pure single-sided deafness and 11 with asymmetric hearing loss. Now first, let's have a look at what happens with the tinnitus loudness in our study. So I will try to give an overview of the tinnitus results, but if you're interested, you can always read more about it in detail in these papers. To monitor, to quantify the tinnitus loudness of our patients over time, we were using a visual analog scale. So patients needed to rate their tinnitus loudness on a 10 centimeter scale, going from 0, quite no tinnitus, up until 10, very loud, cannot get any worse. And as you can see, in the first 3 months after activation, there was a significant improvement in tinnitus reduction, and this benefit remained stable up until the long-term test interval, which was on average 10 years after cochlear implantation. And then at the long-term test interval, when they switch off the cochlear implant again, the tinnitus loudness comes back in the same degree as prior to cochlear implantation. Now let's move on to the effect of the ability to localize sound, which is based on intraoral intensity and timing differences. So here you can see on the vertical axis the localization error. The dotted line represents the chance level of our setup. And as you can see, in both monaural conditions, both groups are performing worse than chance level, but then when they switch on the cochlear implant, the sound localization improves significantly, better than chance level in both groups. The following part shows you the impact on speech perception in noise, which is another situation that's associated with binaural hearing. So our patients who are suffering from unilateral hearing loss, they cannot benefit from the binaural benefits in an unaided condition. So we were curious to find out whether their cochlear implant can restore binaural hearing. And indeed, thanks to their CI, they were able to benefit again from the head shadow effect and from the binaural summation effect. Then I would like to conclude this part of the presentation with what I think is the most important outcome of the study, namely the daily use of the implant. All of our patients wear their cochlear implant 7 days a week, on average 10 years after implantation. And the majority of our patients, they switch on the cochlear implant as soon as they get up in the morning, and they only switch it off again before going to bed at night. So I'll summarize the main benefits once more. After cochlear implantation, Benjamin and all the others reported a significant tinnitus reduction. Moreover, thanks to binaural restoration, sound localization and speech perception in noise improved as well. So it all started more than 15 years ago from a pioneered indication. And since 2013, single-sided deafness is a new indication for cochlear implantation. So to conclude, we discussed our fitting philosophy for single-sided deaf CI recipients, which mainly tries to mimic the natural hearing as much as possible. We proposed a unified testing framework for the follow-up of single-sided deaf CI recipients, and we provided an overview of our long-term results of single-sided deafness in our CI recipients in the Antwerp University Hospital. Thank you very much for your attention.
Thank you very much, Griet, for this very nice presentation. So there is obviously more to long electrodes than just a wide contact spacing, as I think you showed with really convincing evidence. Now, please save your questions for the final Q&A, because now we would like to move on in this program to our next guest speaker. And before we do so, we would like to put up a question again on Mentimeter for you. The question this time, also related to the next contribution from Dayse Távora-Vieira, is: do both SSD and traditional CI recipients benefit from the exact same mapping techniques? Is it yes or no? And it seems that the majority, 75% or more actually, of you out there think, no, you need to apply different mapping techniques in SSD CI recipients as you would in a traditional CI population. So thank you for putting in your opinion there. So it's almost 2/3, 1/3. And the answer to this question will actually come in the next presentation by Dr. Dayse Távora-Vieira. She is the head of Audiology at the Fiona Stanley Fremantle Hospital Group and serves as adjunct associate professor at the Universities of Western Australia and Curtin. She completed her PhD on unilateral deafness, CI, and brain plasticity, and authored more than 30 scientific articles. Her patient-focused research on cortical activity, binaural hearing pathways, and brain plasticity resulted in internationally accepted practice changes. So it's my great pleasure now to welcome Dayse, and please move on, Dayse. The stage is yours. You are muted, Dayse.
Okay. Right. There we go. Thank you very much, Reinhold, for the introduction. Can everybody hear me okay?
Yes.
Yeah. So, and I would like to thank the organizers for the opportunity to be here and share this presentation with Griet, who I had the pleasure to meet many years ago when we were still doing our PhD. So my presentation actually will focus also on optimizing cochlear implant, but focusing on a different aspect of it. So I would like to ask a question: why do you offer a cochlear implant to a single-sided deafness patient? I think that you do this to eliminate the asymmetry of hearing loss, and this is the asymmetry of the input to the brain, and this is what we're going to be discussing here. But before I go ahead, I would like to acknowledge and thank the group of clinicians who do a lot of work in the background with data collection. So when we are talking about providing the brain with a symmetrical input, when you are doing the implant, what you are aiming is to eliminate the asymmetry that a single-sided deafness patient has. So I assume that what you are trying to do is to make sure that the brain is not working this way, right? So if the brain has input from one ear only, that's what you are expecting, that is the work that is putting towards understanding the signal. If you provide an implant, of course, there is not a total asymmetry. I don't expect a total symmetry from a normal hearing and an implant, but what you have to do is to provide this implant in a way that the work for the brain is not too heavy and is a little bit easier to perform. So before I go into what we use in our center, I just would like to very briefly to share with you our outcomes. We have over 150 patients in our center with a purely single-side deafness patient. So in all the discussion that I have, we are not including asymmetrical hearing loss, like Griet presented, we are talking about single-side deafness. So what we are seeing here is the functional outcomes, the speech and noise test in 3 configurations. So is the speech and noise coming from front, this is the CI off, this is the CI on, and this is signal to noise ratio. So you all know that lower on the graph is better is the result. This is the most difficult scenario, I would say, where the speech is coming from the deaf side, from the CI side, and the noise is coming from the normal hearing ear. This is the most difficult situation for the single-side deafness patient. This is when the speech is coming from the front and noise is coming from the CI. There was an expectation that maybe if the noise is coming from the CI side, the results would be inferior, but we can see that actually there is an improvement in all 3 spatial conditions. In terms of localization, we use a 13 speaker setup, and you can see here very clear that when you have a CI on, the arrow of localization is near normal. The opposite is that when you have the CI on, the arrow is much higher, significantly higher. If we look at the quality of life as well, just looking at this SQ, so you are talking about the total score, is not the higher the result, higher the score, better the result. So this is the pre-op up to 24 months. So you can see very clear that the patient rates their hearing much better and a significant improvement in quality of life. So you are all audiologists, or most of you. So I guess the question is, while seeing a very good improvement in outcomes, so why do we need to do anything else? But that's the question that researchers always have, right? Is there anything else that I could be doing? Is there any room for improvement? So we have been asking this question, and we learned from very early on in our center that the single-side deafness patient need a different approach. They have to have a pre-surgery counseling much more in detail. They need to have the right expectation. They need to have active rehabilitation. So the passive rehabilitation that we use with bilateral deafness does not work with the single-side deafness. But we are mapping these patients using the same strategies that we use with bilateral cochlear implants. So we proposed a few years ago that maybe we could look at alternative method to see if the brain is actually receiving an input that is symmetrical. Is the brain receiving an input from the normal ear that's symmetrical to what is coming from the CI side? So we published this back in 2018. It's purely a proof of concept. We used the cortical auditory evocative responses to see if the map that the patient was using was optimized. So what you can see here, we recruited 19 subjects. They were all CI users, and they had a lot of experience with their CI. We run a cortical test with them using the HearLab system, which means that we present 4 different sounds in low, m, g, t, and s. So low, mid, high, and very high frequency. And we recorded using the CI only condition. So when we had the CI off, there was no response whatsoever. When we had the CI on, we had a nice P1 and P1, P2 complex there. So that was our first paper. We did not, it was a proof of concept. We wanted to see if it works, but we did not look at latency, anything like this. So that was our next question. Is there any difference in latency, and is there any correlation with speech understanding when we compare the normal hearing ear with the cochlear implant? So this was our second study. It was published back now in 2021. What we did was what you see here. you see the 4 speech tokens that we used, so going from low to high frequencies. I hope that you can see well on the screen. And what we did was, this is for CI, the signal coming from the CI. This is the signal coming from the normal hearing ear. And what we found was that looking at the N1 response component of the cortical, there was no significant difference for the latency of N1 when we compared normal hearing with the CI side. So we looked at, okay, P1 and N1 is more detection, so let's look at a little bit higher in the cortical pathway, and let's look at P2. And surprise, surprise, so what you are seeing on the screen, again, the speech tokens, M, T, D, and S. And this is the CI, and this is the normal hearing ear. And again, we did not find any difference for P2 latency comparing normal hearing ear with the CI. Okay, you can think, okay, the detection is the same, the brain is receiving the signal simultaneously, so everything is symmetrical and everything is okay. So we had one more question, and how is at the higher level? How is the interpretation? How is the processing of the signal? One thing is to detect it, another thing is to interpret it. So we went a little bit further and we used a little bit more sophisticated setup. We used a CAP and we used a high density EEG machine. And we recorded what you are seeing on the screen is the N2, P2, N2, P300. That is much more related with cognition, with processing, with memory. There are several studies on neurology, on dimension, using the P300. So what we wanted to see is how is the brain actually processing the signal that is much more degraded coming from the CI compared with the normal hearing ear. And we had actually a really nice surprise. So I'm just going to talk you through here. What you have here, what we used was, we used audible paradigm, which means that you have a target sound that you have to identify among a lot of non-target signal. So the CI uses the way that we presented the sound to the normal ear using a headphone, to the CI using a direct audio input. Well, we are very lucky to use the Magellan because we can do that. So what you are seeing here, I'm just going to show you the black line. This is the CI, and this is the normal hearing ear. So there was no difference in morphology. What we found was there was no difference in morphology compared for the P300 and for the N2, comparing the CI and the normal hearing ear. And what is interesting as well is that when we did this scalp map, there was no significant difference in the activation of the brain. So that is normal hearing ear. That's for the N2, that is N2 normal hearing ear, sorry, CI. And this is the P300 for the normal hearing ear and for the CI. So what we conclude is that the brain is using the same, the brain is receiving the signal symmetrically, the brain is using the same strategy, the same methodology, the same process, I would say, to process the sound coming from the CI side and from the normal hearing ear. What we found that was different was that the reaction time, at the time that the patient took to interpret the target signal with the normal hearing ear was much faster than from the CI. I think that is a very interesting point because, okay, the brain is using the same process, the signal is a little bit degraded, therefore the brain needs a little bit of more time. But I think that the CI is doing a really, really good work there. So, but then you may ask, oh, well, that's very fancy, but what I'm going to do with this information clinically? So I'm going to present what we did recently with our group of 66 single-side deafness patients. What we did with them, of course, they have been optimized. They use the same method that we all use to set the MCLs, where we use the loudness scale when we rely on the patient subjective. But we know that maybe the single-side deafness patient, they are comparing, and we ask them to compare the single-side, the CI side, with the normal hearing ear. So it's perfectly possible that they tend to set it under the response that you would like, or maybe they set it over where you would like to. So what we found was that from the 66 patients where we did the cortical test with them, only 20% of them actually did not need any change on the map. 80% of the patients need some sort of change on at least one sound, which means that on that phoneme in particular, that is speech token in particular, that corresponded to a certain frequency range, we went back to the map and adjusted it, and then we retested, and we did the speech test before and after. So that's this response here. This is the results that you are seeing on the screen. So 80% of them needed optimization, at least one is speech token. Then we optimized them. We could optimize 62% of them, but 38% of them could not be optimized. Most of the time, the issue that we had was, everybody knows, is the high frequency. So the S sound was the most difficult to optimize. The main issue was tolerance, nothing new under the sky for anybody. Another thing that we are considering is that for all these 66 patients, some of them were still very early in their journey. They were recently implanted. So it is possible that if we do this again in another few months, the response will be different. But what is more important is, if I go back here, this group here that we could optimize every single speech token, we did a speech test before optimizing and after optimizing, and this is the result. So that's a typo there that I realized this afternoon, but it was too late to fix. That is pre-surgery. So pre-surgery, they had a signal-to-noise ratio, now a mean of 6.7. Post-op, there was a significant improvement. It went down to 1.4, but after we optimized the implant using the cortical, it went even lower to 0.4 dB SNR. I think that is quite impressive, to be honest. We have been very lucky with Medel because many of you may be thinking, well, that is very nice, but we need extra equipment. So Medel has implemented in the Maestro electrically evoked cortical response, and we have tested this ourselves, and this paper will be out by Ian Hearing in a few weeks. What you are seeing here, this is the cortical response. You can see P1, N1, P2. The black line is our old method using the HearLab system, which means that the sound is presented by a speaker. And if you look at the light gray, is the electrically evoked cortical response presenting use the MCL of the map. What we wanted to see is that compatible? Is that comparable? Sorry. And you can see perfectly there is no discussion. For all the speech sounds, they are comparable, which means that Medel has made our life much easier because we can use electrical stimulation and measure our cortical response and ensure that our patients are actually optimized. And you may ask, does it matter? Well, I think that does. Any improvement that we can make, it makes a big difference. I'm going to show you one example and I will finish. This is a map of a patient who was recently transferred to our center. He has single-side deafness. If you have a lot of experience with Medel, you would look at this map and say, well, that's a little bit not what I would expect. Then I'm going to surprise you. We did a cortical with him before changing his map. And this is his cortical. This is P1. You don't need to have a huge experience with cortical response to say this is massive. This patient is being overstimulated. So we did his map again. This is how he went home. And as soon as I got home, he sent us an email saying, thanking the group for setting him up with the brainwave program. That's how he would just describe. I have returned home with my hearing restored to previous level, but to an even better sound. And I think that's why we do research, for no other purpose than to improve the patient quality of life. And as Griet has said before, I think that there are a lot of things that we need to consider to make the signal symmetrical, everything that is possible to make the signal symmetrical. And one of the things that's mentioned by Griet is the depth of the electrode. We want to stimulate the right cell, and we have to have a very strong counseling. We need early benefit. It's very easy for the single-side deafness patient to put it away. We need a specialized auditory training, and we need early optimization. Well, that is me. I hope that I have convinced you to think about it. Thank you for listening.
Thank you very much, Dayse, for this fascinating presentation. I think you showed really very nice evidence on the benefits of assessing cochlear implant maps in SSD individuals, for that matter, using objective measures. And it's great also to know, I guess, for the audience that similar tools are available in the Maestro software as well. Before we go into the Q&A session now, I would like to catch up with a tradition of Experts Online and ask everyone out there to please activate the camera. And if you have a cup of tea or a cup of coffee, we'd like to make a shared toast and actually take a group picture of this event. So please raise your cup, make a big smile. All right, great, thank you. So let's go into the Q&A session now, asking some questions. Any type of questions are welcome. You can also activate your microphone, of course, and just say out your question live. Or if you prefer, please feel free to also type in the question in the chat. There is already one question by a Mrs. or Mr. Gell to Griet, asking to describe the principle of post-op sound localization testing.
Yes, I think I'm unmuted again, right?
Yeah.
Okay, perfect. And maybe I will share my screen again because I've got a picture of our sound localization setup. I think that's easier to explain how we test our sound localization in our patients. So here you can see a picture of our booth. So we are testing in a horizontal plane, going from minus 90 degrees up until plus 90 degrees. Then there's a broadband noise coming presented to the listener, and then the patient just have to answer where the sound is coming from. A typical result is plotted on such a graph. So ideally, when a patient can localize where the sound is coming from, so a normal hearing patient, then the data points would lie on this diagonal. So the response of the patient corresponds perfectly with the direction the sound is presented from. This is just an example of a patient with a single-sided deafness in an unaided condition. So for example, prior to surgery or 12 months after implantations, but with DCI switched off. So as you can see, the data points are not lying closely to the diagonal. But then when they switch on the cochlear implant, for example, this is a patient with an Opus 2, an older speech processor, then you see that the data points are coming closer to the diagonal, and so that the sound localization improves with only a localization error of 37 degrees, which is a very nice result for a single-sided deaf patient. And so these are the results that I shown in my presentation. So in the condition, the binaural condition with the CI and the normal hearing ear, both open or free to listen, then you see that there's indeed a significant improvement and a good sound localization in our patients with unilateral hearing loss. I hope that this answers your question.
Thank you, Griet. There is another good question by Gunnar, who is asking, what's the idea behind increasing the sensitivity to 100% for the SSD patients?
Yes, for that question, I don't have a research or an evidence-based answer ready, but what we experienced is that in our patients with tinnitus, when they have really access to every sound, so really sensitive system, 100% sensitivity, that it has the most impact on the tinnitus right from the start. Then maybe after 1 or 3 months, they are complaining, oh, I hear the clock ticking, and then we can adjust and set it to 75, for example, but we start with really everything open, maximum sensitivity.
Good, thank you. I would have a question for Dayse, if I may. Dayse, you showed CABS being a very sensitive tool actually for adjusting cochlear implant maps in SSD patients, probably not only in SSD patients. Do you think that this method would also be suitable early on? Or would you go for another objective method in early fittings, like even activation, in patients where you are not really able to get a behavioral response on stimulation levels?
Yeah, that's actually, it's a very good question. One of the questions that we are trying to answer at the moment is actually how early we actually can do the cortical, because what we are not using the cortical to set the map, we are using the cortical to verify the map, right? For the audiologists who work with hearing aids, we know that we know verification for hearing aid for several decades, and we don't have it for, well, we do have it for CI, but it's not widely used. We still rely a lot on subjective. I think that the ESRT and the auto ART on the Medell particularly is fantastic. Honestly, I have to say that it's fantastic to give you the first map, what the cortical measure will not give you the first map. I think that would be pretty hard to get a very nice cortical reading at the switch on. Probably would be difficult. I think that the ESRT is fantastic, particularly for the young kids, people with cognitive decline, and the auto ART as well. Although I personally prefer the ESRT, I think that is more reliable in the correlation with his speech is much better.
Good, thank you, Dayse. There's another question from Nouf for you, Dayse. First of all, thank you for the great presentation. Regarding the study showing the difference of P300 between CI and normal hearing ear, when was it administered to the patient? So after how much time of CI use?
Yeah, that's a good question. This was done, they had at least, for the P300, they had at least 12 months of experience with the CI.
Okay, and another question that maybe either Dayse or Griet can answer, from Telly Greenstein. They found out that changing map law to 750 sounds more natural. Do you have similar experience with this feature, so map law compression, as one fitting parameter in SSD mapping?
Yeah, in Antwerp, we start with the 1000, setting MapLow at 1000, and only seldom, very rarely, maybe sometimes in older patients, we adjust it to 750, but that's not in the majority of the cases. There we keep the 1000. I don't know.
So even
Dayse,
slightly more compressive.
Yeah. I don't know, Dayse, whether you have the same experience.
I actually use 750, but I wouldn't be able to say that because I use 750 with most of the patients. I wouldn't be able to agree with you, Carly. I don't know if that's the name. Yeah, no, I haven't looked at these particular, and not even there's a research question or clinically.
And if I may add a quick question, do you also do loudness balancing across the ears when you're mapping SSD patients? Or is there any tips or tricks that you would have perhaps to that extent, how to achieve a balanced loudness?
Yes, so, we do, definitely.
Mm-hmm.
And we do it actually at the fitting. It's for, I think that is very important that we do use a different strategy. We are not very gentle with single side deafness patient.
Mm-hmm.
We are very hard with them, to be honest, because in my opinion is if you have something that is not really doing anything, you are not achieving any benefit, you are going to give up. It's much easier to put it away. The reality is we are all clinicians, and we know that with a bilateral deafness, we can do a pretty average map and get away with it because the brain doesn't have anything to compare. But the single side deafness, they have a normal hearing to compare. So you actually need to have a pretty decent map.
Mm-hmm.
Yeah.
Okay. There's another question from Imam to you, Dayse. At which level do you record CAPs, cortical auditory evoked potentials?
55.
55, all right.
Yeah, the free field one, 55.
With free field presentation. So you're obviously also masking the contralateral normal hearing ear. At what level?
We did actually, at the first study that we did, was one of the questions was what was the level of masking that we were not recording response from the contralateral ear. So we, all the 19 participants, we masked at 60, 65, and 70 decibels, and we found that the effective map was at 70. The reality is it's pretty much impossible to eliminate all the interference that is coming from the noise. But as we were using the patient as their own control, I think that we can be confident that what we were recording was from the ACI.
Mm-hmm. And have you also tried providing direct input to the cochlear implant for the sound when recording, or did you always stick to free field?
For the P300 study was direct out input.
I see, okay. Mm-hmm.
Yeah. So we are talking about 3 different studies here. One was the speech tokens presented free field. So in this case, it's free field is aided. There is another study where we stimulated just using the coil, at the MCL level to see if we would record the same cortical response using electrically evoked, electrical stimulation. And we, for the P300, was direct out input for the CI.
I see. Good. Thank you very much. And we're closing in, and I think we're almost completing the hour. So I would like to, first of all, thank our wonderful presenters on sharing their really year-long experience on managing cochlear implant recipients with single-sided deafness and getting the best outcomes for them with their mapping and fitting techniques. I would also like to thank the participants for tuning in. And at this point, I would also like to hint you to the next Experts Online, which is a Experts Online on middle ear implants or power bone conduction in mixed hearing loss. Actually, sorry, I have the wrong slide here. It's a Experts Online on my cochlear implant surgical workflow with Autoplan. So we heard Autoplan also in a presentation where it was mentioned in conjunction with optimizing individual frequency place allocation in a cochlear implant map. In this Experts Online, Autoplan will be highlighted more from the surgical point of view. And the guest speakers in that Experts Online are Dr. Peach and Dr. Ruck. And it will be scheduled on June 16th. So if you have time, please tune in again. And thank you all for participating in this Experts Online.